To everyone joining us today for this webinar on mental health and human rights. Let me briefly introduce myself first. I'm Claudia Braga. I'm from Brazil. I'm a mental health expert, and I have been working on the past years on the shift of paradigm and services in Brazil, downsizing and closing down long-term care institutions, and implementing community-based mental health services in line with human rights standards in Brazil. I'm also a researcher, and I have been collaborating with the WHO Quality Rights Initiative since 2016. Today, we are holding the last webinar of the Mental Health for All webinar series of the year. And I think it's great that we will wrap up all the previous discussions of this year, but also point the way forward on mental health for the next years with a discussion on how to provide a rights-based approach to mental health care. We know that defending and promoting human rights in mental health services and practice is urgent, and we also know that the violation of rights of people with a psychosocial, intellectual, and cognitive disabilities is a reality, including in mental health services. We still need to address issues such as institutionalization, the denial of people's legal capacity and rights, the lack of mental health services, among other problems. A lot have to be done everywhere to improve the quality of rights and the quality of services. And of course, it's crucial for countries to have mental health laws in line with human rights standards and to implement mental health policies and plans also aligned with it. Also, funding investment on community-based mental health services is essential. And I think here is important just to state that we need, of course, community-based mental health services, but it needs to be more than only located or based in the community level. The services have to work really to promote social participation, to respect people's rights, to understand people's real needs, which includes, of course, having access to mental health services, but also having a house, having a job, having friends. And also services need to work in a way that people are able to have meaningful lives. All of these changes are related with another one, the change of paradigm. Well, the good news is that it's an exciting time for changing, having the UN Convention on the Rights of Persons with Disability as an important landmark, not only because it's a legally binding document for those countries that signed it, but also because the discussion promoted on this convention really impacts culture, and this affects and matters for everyone. Now there are great opportunities to move away from approaches that focus on biomedical models of care and to move away from practices that violate human rights. And this starts now. I'd like to mention one of these opportunities here, the Quality Rights e-training, which is part of the Quality Rights, the WHO Quality Rights Initiative. For those who are not aware of this initiative, the WHO Quality Rights Initiative aims to improve the quality of care in mental health and related services, and also aims to promote the rights of people with intellectual, psychosocial, and cognitive disabilities. I invite you all to access the Quality Rights website, take a look at the documents and tools available there to promote rights. Specifically, I'm going to talk a little bit more about this tool, which is the Quality Rights e-training. It's an e-training. It focuses on mental health, recovery, and community inclusion. And I do think it's a great opportunity to change attitudes and also to increase the quality of the practice on mental health services. Saying very briefly, this training is composed of 6 modules, and it covers many aspects and topics related to mental health and human rights, such as supporting friends, families, and colleagues with their mental health, tackling stigma, discrimination, abuse, and coercion in mental health services, and taking actions in support of transformation of mental health services towards a person-centered, a rights-based, and a recovery approach. Once all 6 modules are completed, an official WHO certificate is awarded to learners. This training is currently available in 11 languages, including English, French, Spanish, and it's open to all people. You can find the link to sign up to the e-training in the chat, and I invite everyone to take a look on it and start this training as soon as possible. So moving on our agenda today, we are going to talk about important issues on mental health and human rights. we are going to highlight the importance of mental health laws, policies, and programs, being in line with the international human rights standards. And we also intend to bring a spotlight to human rights abuses, such as stigma, criminalization of suicide, consent issues, among others. Because as I mentioned before, human rights violation is still a reality. And of course, as our goal is to change this reality, we are going to discuss it in the sense, in the direction on how we can move forward to work and to implement human rights. So that being said, I'd like to thank the United for Global Mental Health for the invitation to chair this webinar with such a great group of panelists. And now I would like to invite each one of the panelists to say a hello to everyone and to present yourselves. And could we start with a hello from you, Michael?
Yeah, thank you very much, Claudia. I hope you can...
We cannot hear you very well. Maybe you could...
Hello, everyone. Hello.
It's perfect now, Michael.
You can hear me well now, yeah?
Yes, yes.
Yeah, thank you. Hello, everyone. It's a pleasure and an honor to be able to contribute and speak to this webinar by United for Global Mental Health. My name is Michael Njenga. I am a person with a psychosocial disability. I work for CBM Global as the regional mental health advisor for Africa. My area of interest is in the area of legal capacity, independent living, and being included in the community. And broadly, a lot of work around legal harmonization. I also work for the International Disability Alliance, supporting their capacity building program on the CRPD and Agenda 30, the SDGs and Agenda 2030, and it's a pleasure to be here. Thank you very much.
Thank you, Michael. You're welcome. Dr. Sultana, could you please introduce yourself?
Hello, this is Dr. Zeenat. I'm from Bangladesh. I'm working in an organization known as Bangladesh Center for Communication Program. It's a national organization. And we are actually, our key focus is actually strategic communication for social development. And under this program, we have a number of health-related issues and programs. And I'm working there as a program director. And as a part of that, I'm actually overseeing a number of development programs, especially focusing on health. And the activity that we are having is including capacity building, research, then awareness building and campaign, this type of, there is monitoring and evaluation, this type of different activities we are implementing. And under this activity, we also have activities for mental health issues. And we are implementing projects that is related to community-related mental health issue, as well as having a very small scale surveillance on suicide-related issues. So that is in brief from my end at this point. Thank you.
Nice, thank you. And Christian, could you introduce yourself, please?
Good morning, good afternoon, good night to everyone. My name is Christian Guzman. I am from Peru. I work with CARE Peru. And I'm the national coordinator of a regional project called Fronteras Invisibles, or Invisible Borders, which is a project devoted to work with migrant and refugee women, especially with an special focus on women survivors of gender-based violence and with mental health, different mental health needs. And also I work with IASC, ESC, right? I just finalized a couple of months ago a mission on Honduras with the MHPSS reference group, boosting coordination on mental health and psychosocial support within the humanitarian network in Honduras. So that's on my end.
Amazing, thank you. Benjamin, welcome. Please introduce yourself.
Hi everyone, my name is Benjamin Ballah. I'm from Liberia. I work for Cultivation for Users Hope. There's a server user movement with lived experience people. And I'm also a classroom teacher, a government school teacher. So we are here as an advocate group pressure group on the government, working with the government, making sure that mental health issues are factored into the UAC and making sure that people with lived experience in mental health receive the necessary treatment that they need to have to be part of the society and the global world at large. So we are here to share with you the few things and what we are doing here with the government of Liberia and other civil society organizations to make sure that mental health is no longer under the rug. Thank you so much.
Thank you, Benjamin. Fantastic. So before starting the discussions with my first question to the panelists, I'd like to invite you all, the webinar participants, to really submit your questions for this panel. We all need to talk about the challenges on promoting human rights, so I encourage you to join us in this debate. To start the discussion, Michael, could you please explain to us what does it mean to take a rights-based approach to mental health services? And also, as I mentioned before, the CRPD is really important. What does the CRPD say around mental health?
Yeah, thank you very much, Claudia. So just to reflect a bit in terms of what does it mean to take a right-based approach to mental health services, I'm going to make a reference to the criteria from the Committee on Social and Economic Rights about the right to accessing services. So I think the first important thing is about making sure that the services are available within communities. The second is the issue of accessibility. So are they accessible? Are they affordable to people within their communities? The other issue is about, of course, affordability, and there's the issue of acceptability, which is really important. Are mental health services adapted to local context? Do they respect personal dignity and autonomy? Are they person-centered? And are they of the right quality? So for me, that criteria broadly is very, very important. The issue about availability, accessibility, affordability, acceptability, and services being of the right quality. I mean, the other thing is really also to re-emphasize the paradigm shift from the World Health Organization in terms of reforming mental health services, where that services needs to be recovery oriented and promote and advance people's human rights, ensures their participation and their inclusion, of course, in the community. And then that in sense means that we have to fundamentally respect all the human rights of persons who are accessing mental health services, within, of course, different contexts. So I think for me, that overall would be my overview in terms of then what services should look like if they have to comply with human rights. So in terms of broadly thinking about the CRPD, so I think for me, the most important thing is it is easier to understand the letter of the law, but we need to understand the substance and the spirit behind the law, and also in terms of how do we transform the generalities of the law into practice, because there are things which will be addressed by the law, there are things which will be addressed within the law, but in the context of mental health, there are a lot of things which have to be addressed beyond the law. So, for example, awareness raising might not specifically be something that really is family ingrained in the law. So for me, it's about understanding the key concepts in terms of the CRPD. I think that for me is really important. And always when I'm speaking about the CRPD, I really like making reference to Article 3 of the CRPD, on the general principles of the CRPD. Because I think for me, if we were to observe just the general principles in Article 3, then that would make us to have services and laws which complies with international human rights standards and practices. So for example, the issue of respect for inherent dignity, individual autonomy, and the freedom of people to make their own choices, non-discrimination, full and effective participation in the society on an equal basis, the issues of accessibility, equality between men and women. I think for me, if we were to observe those core principles in Article 3, then it's very, very easy for us to be able to sort of have services and laws which complies with the Convention on the Rights of Persons with Disabilities. I don't know, my last point is in terms of if we were to make laws to be compliant with the CRPD, then we need to think about a couple of things. So there are key elements which we need to put into consideration. So the first one would be, so if we are doing a program, is there a paradigm shift in the situation? So for example, are we advancing community participation or inclusion, or are we, encouraging segregation, discrimination, and people being in institutions? So I think that for me is very, very important. How are we changing broadly the situation? The second thing is the process. It is very critical to observe the process, and especially to ensure the meaningful participation of people with lived experiences in line with the general principles of the CRPD and in line with the general comment number 7 on Article 4.3 and 33.3 on the full and meaningful participation. Then I think we have to look out at the outcome. What is expected? Are we really achieving the shift that was promised? So when we are referring to accessing mental health services, what does that mean? How are people, benefiting? Are they participating? Are they being part of their communities? So I think overall, there have to be key element in terms of how we analyze bills, laws, and programs in terms of compliance with the CRPD. So I think I'll stop there and then, yeah.
Fantastic. Thank you, Michael. I think you raised very important questions. Benjamin, I was wondering if you could share with us what forms of stigma and human rights abuses do people with mental health conditions face in Liberia.
Okay. My name is Benjamin. Once again, when it comes to stigma, forms of stigma in Liberia, I would basically like to look at 3 forms of stigma that are mainly experienced in our own country. That is structural stigma, then public stigma, and then we talk about self-stigma. Those are the 3 types of stigma that is common in Liberia, especially for structural stigma, where that will take me to Article 25 of the CRPD, which talk about health for all, where person with disability should not be discriminated or maybe restricted in going to certain health facilities. But we see that common in Liberia here, as well as with persons with psychosocial disabilities. So structural stigma is one of the type of stigma experienced in Liberia. Number 2, I will talk about public stigma. Public stigma is one of the stigma that is very much common in our own country, Liberia. You find people discriminating persons with psychosocial disability against certain places, certain public places that do not allow persons with psychosocial disability to go there. And if that happens, that will take me to self-stigma. Self-stigma in the sense that if someone says something about you and after a certain time, you tend to believe that what they are saying, so you self-stigmatize yourself. or the people say in Liberia, it's common that they refer to people with mental health conditions as crazy people. So you say, okay, once the people say I'm crazy, okay, I'm crazy, then you tend to behave that way. So that's a stigma. So basically, if you ask me about stigma, those are the 3 types of stigma that are common in our own country.
Thank you so much, Benjamin, for this. Dr. Sultana, I'd like specifically to ask you about a huge challenge that some countries face on mental health and human rights field, which is the criminalization of attempted suicide. So from your perspective, is the criminalization of attempted suicide a step away from rights-based legislation? And also I'd like to ask you, how does that impact the rights of persons with mental health conditions?
Thank you. Yes, criminalization of actually attempted suicide create barrier for the right-based legislation. In Bangladesh context, you know, the suicide is still considered as a criminal offense, like few other countries. So here, whoever attempt to commit suicide shall be punished, either in the form of an imprisonment or with fine or with both. Here in Bangladesh, we don't have any national suicidal surveillance system yet. There's a national surveillance system, but there is no evidence that criminalization reduces suicide. Rather, we can say that it will hinder the high-risk group or those who attempted to commit suicide from seeking help for their suffering and for their mental health condition. Actually, there are diverse factors that driven an individual to commit suicide in a country like Bangladesh, in a third world country, and where there are a lot of problems exist. So currently the suicidal cases are increasing, especially among the young generation, especially in post-COVID situation, during COVID pandemic, and also during post-COVID situation. Hence, for prevention of suicide, actually we need to look at the root causes and come up with a plan for addressing those to improve the mental health status, rather than criminalization, because it cannot play any special role in prevention. And as we know, the legal consequences, and as for the religious, as just Benjamin was mentioning about stigma, here also we have religious stigma, we have social stigma, and those actually, in fact, hinder the suicidal case disclosure. And therefore, those who are attempt for suicide, they are not seeking medical attention. They are not availing the support services. And therefore, they become more high risk and their complications become more and more indeed. But they have the right to get help. And as the cases are underreported, therefore, we don't have enough support system indeed. Telling the truth, we don't have any community-based support system like that, considering the level of cases we have, because there is a lot of underreporting taking place here in Bangladesh. So all this actually having an impact on the right of a person in a negative manner here. So that's why we think that we really need to work on these issues, especially on the right of a person to getting the support on mental health issues. The system is not yet established, not at the community level, not at the health system level. And if we talk about the household level, obviously stigma works a lot here.
Thank you. Very impressive. Quite a challenge. So now moving from the other side of the globe, Christian, it's known that Peru is advancing on the implementation of mental health services, as showed, I remembered, in the new guidance on mental health services from the WHO Quality Rights Initiative. But I'd like to hear from you, what are some of the key challenges that you have faced when providing mental health and psychosocial support to refugees in Peru? Could you share with us, please?
Sure. Thank you for that. Yes, on the side of service providers, for example, we still find prejudice, discrimination, and xenophobia around the care of these particular population, you know, and it's one of the key barriers for the access, actually, xenophobia and discrimination. And this prejudice, one crazy thing, if I can use this word, is that these prejudices are largely fueled by the local press that attributes these stigmas related to crime and death to the migrant population, because we know factually, we have evidence that the criminalization and all these you know, all the indicators related to criminalization, actual criminalization, are going down in Peru. You know, since at least 5 years ago, criminalization started to go down, but there is this created feeling fueled by the media that we are facing a wave of criminalization, and that wave is directly linked to migrants and refugees. You know, it's part of a political agenda for conservative political actors. You know, so that's part of the reality here. So that's one big challenge here. And you know, service providers, they are not coming from Mars. They live within the society. So they are part of the society. So in that sense, they reproduce this prejudice as well. Another challenge is that you know, we've been working a lot strengthening capacities within the public system. So we've been providing trainings to service providers, and there is some slowness in order to adopt or to take on new tools within the public care system, generally focused on clinical work. Although we made a great progress with the implementation of this model of community mental health centers within Peru. Currently, we have more than 200 community mental health centers around Peru. The focus continues to be more on clinical services. And one thing that we've been trying to promote from this project is strengthening the work on community and with community leaders, strengthening their organizational capabilities. So we need to move forward on that focus, I think. And when also another challenge is that when we decided to focus on community work, on working with community leaders, we found that the way in which most humanitarian organizations have traditionally related with migrant and refugee community organizations has been focused more on the identification and referral of, you know, beneficiaries or cases, but the focus on promoting organizational capacities, again, it's still very incipient. It's still a challenge to be take on. So those three for starting.
Okay, thank you for that. Well, there was a great round of questions. I think I agree with you all, you know, that tackling stigma, discrimination, abuse and coercion in mental health services, it's something that we need to be done. We need to do in all countries and at all levels. Even in the countries that is counting now with mental health systems. So thank you for that. I'd like just to remember to the participants that you can submit for your questions to the panelists. But before going to that, I'd like to pose some more questions for the panelists. Benjamin, I'd like to start with you again. What are some of the steps your country is taking to bring mental health care in line with the CRPD and other international human rights instruments?
All right. You talk about steps that my own country, my government is taking to tackle mental health issues. Let's say for the first step, we talk about public documents, policy documents. Our country is very good at crafting policy and strategic plans. So policy documents are very good in terms of supporting persons with psychosocial disabilities. So that's number one. We have good policy documents that can, like you know, we just had the mental health policy for the last 5 years that got expired last year, and the new one has been worked on and has already been passed into HEM bill. So those are things that people with lived experience can hold the government accountable. Oh yes, you drafted this. You say you will have mental health, psychosocial or clinics or hospitals all around the 15 counties, and you have not done this XYZ. So those policies will be there to checkmate the government in terms of supporting people with psychosocial disability. Number two, we talk about bills. We talk about the equity health bill. It has also been passed yesterday. The country representative for WHO, Dr. Peter Clement, also spoke on that. So policies are very good. The equity health bill has been passed also. Then we have the Liberia health financing bill that has also been passed also. So those are good instruments. And lastly, I would like to mention that the government is also leaving the responsibility of mental health issues, mental health treatment with partners. So partners are more involved in supporting mental health issues. We talk about the Cairo Center, Medicine Sans Frontiers, Partners in Health, and you just named them. So, and my own steps that what I would like to commend the government for is that they open the door for partners to help to do more, because they themselves are not capacitated. As you know, Liberia is a very low and middle income country. So they have opened their arms to partners to help them tackle this issue. So policy documents are very good. Thank you so much.
Okay, thank you, Benjamin. Well, Dr. Sultana, you talked about the criminalization of attempted suicide. I was wondering if you could share with us what needs to happen for suicide survivors in your country to get the human rights-based support they need for their mental health. Sorry, your mic. You need to turn on.
Sorry, yeah, right. Providing right-based support to the survivors after suicidal attempt is really an important activity. However, as I discussed before, that the suicidal survivor in Bangladesh are usually impacted by the social, religious, and cultural stigma or taboo, which actually prevent them to seek any support, and they don't feel comfortable actually also discussed about it. They like to hide it. So though they need the support badly, but they're seeking, the practice of seeking the support is really very limited. They're under trauma, they're under stress, they're under trauma. But at present, we don't have enough community-based support system even to provide them support here. But a positive thing is that government should play an important role here, and Bangladesh government already actually committed now to consider suicide as one of the priority issue for non-communicable disease. And there are some institutes also available, but the coverage of their service is not that wide through which they can provide services. We have some limited safe place services for the suicidal, those who are survived from the suicide attempt. And from there, they can have some care and support. They can get some healing conversation, some counseling, psychosocial counseling supports, some place where they can express their feeling. This mostly those are managed by some non-government organization and to some extent at the government institutes. But these services are not that wide range. So it is actually very important for a country like Bangladesh to create an environment that is safe and open for them, where they can actually share their feelings, express theirs, and seek support. And under these circumstances, I like to mention that in Bangladesh, we actually need to formulate national suicidal prevention action plan. We have policy, we have a strategy, but we need to, that is for the mental health as a whole. But we really need to have something very specific regarding suicide. As I mentioned during my introduction, that we did a very small scale suicide surveillance study in Bangladesh in a suicidal prone area. And we see that how people are actually don't like to disclose these cases. They are really afraid of any type of harassment by the law enforcement. Even they don't like to discuss it with their nearby healthcare services. If they seek service, they service from some other areas, not in their own area. So there is no documentation at all. So we really think that for that, we need to also involve all the stakeholders. We need to have a cross-stakeholders activity involving other partners, organizations, along with government. It is not only government, we also need to have that. And we really need to have a wide-scale mass awareness regarding suicide. As I mentioned before, that in Bangladesh, it is difficult to say the rate of suicidal cases, as we don't have a very clear surveillance and there is a number of under-reporting. We have system, but reporting is not done here appropriately. But even though we can say that about 39% suicidal rate is there and the rate is increasing, there are some small scale study took place, especially post-COVID. It shows that the rate is increasing, especially among the young. So we need mass awareness. We need to do capacity building, especially in terms of social counseling, especially in terms of social coherence. If we like to address the stigma, we really like to bring a community resilience building. That's very much needed. We need to build the support service and should have a very competent staff, those who can manage and handle this type of cases here. And that also needs strong leadership. But however, as we now have a strategy and a Ministry of Health and Family Welfare is leading this thing, we are really looking forward to have a strong policy, implementation of our policy in future. But currently, honestly speaking, they're not even coming up to seeking services. That is the reality part. Very few, very few, very few. Thank you.
Okay, thank you. We have a lot of work to do to promote human rights indeed. And I agree with you that we need to involve all stakeholders. And Christian, in your point of view, what more can governments and ministers of health do to protect persons with mental health conditions that are vulnerable to human rights violations?
It's incredible, right? We might come from very different areas and so on, but we share many common problems, actually. So one thing that probably the government could do more is including a specific training on human mobility. that's really obvious, I think, but it's not yet done. So they actually UNFPA did just a few months ago, and they actually published a study regarding cultural barriers on service providers for the within the public health system. And this issue about xenophobia came up at one of the first main problems. So it's kind of obvious, but it's not yet done, including a specific training on human mobility and obviously gender equality, MHPSS, and humanitarian interventions within induction processes at the very beginning when they include a new service provider. I think that's something very important thing to do. Another one could be promoting closer articulation on the ground, right? Between, the public system services and humanitarian actors with MHPSS programs. So in order to make these referral and counter-referral processes to flow better. That's something very important to do as well. And also placing a greater emphasis, when I say the emphasis, I mean on training, financial resources, and personnel on the implementation of a community MHPSS strategy that aims to strengthen community resilience through the accompaniment of community groups, promoting community leadership. They do two main, work within the community. One, facing, challenging, changing stigmas around mental health and psychosocial support, mental health needs, but also early identification on mental health needs. So they prevent the, chronification of mental health needs. So it's strategic even. So that's very important. And finally, we think implementing participation and oversight mechanisms, formal mechanisms for people with lived experience and mental health needs. That's something that needs to be strengthened here in Peru. And I think that's something that we all probably share. So the services and the strategies of the public care system have to be fed by the vision of experts, by experience. So those four could be a good start.
Yes, that's great. I agree with you that we need to listen more to people with lived experience to work with the systems. So my last question before moving to the audience questions is for Michael. Michael, what are your key recommendations for countries seeking, yes, that's it. What are your key recommendations for countries seeking to bring their legislation, policy, and programs on mental health in line with international human rights instruments?
Yeah, thank you very much. I think for me, a couple of things. First of all, we have to rethink about the scope of mental health laws, because sometimes we feel like mental health laws go beyond legislating on health issues. So for example, if it's the issue of legal capacity, this is a mental health law. Legal capacity probably should be addressed in a separate law, substantively dealing with legal capacity. So the issue of guardianship and property, again, they are brought into a health law. So I think the first point of consideration would be, of course, we really need to think about the scope of the mental health laws and what should be covered in a mental health law, because it fundamentally deals with health. It shouldn't deal for me with the issue of political participation, the issue of property. That should be legislated in other laws. So that's one key thing. I think the other thing which I highlighted is sort of we need to probably think more around when we are talking about complying with international human rights standards. So what indicators and tools do we have? Because we need to have key indicators to check whether a program or a policy or a law complies with international human rights standards, and that's really, really important. And I know there's some work going on from WHO and also from the Office of the High Commissioner on Human Rights. So I think that's very important. The other thing, of course, really to emphasize the role and the need to strengthen organizations of persons with psychosocial disabilities as people with lived experiences to be able to contribute to the law reform process. And also for us to be very, very careful to address the power imbalance normally which exists, especially when we are legislating mental health laws. So for example, just to give in Kenya, when we are trying to reform the law, then you will have probably a room where 95% of the people are medical professionals, and we are trying to talk about a human right-based approach. Then you bring in two people with lived experience. So that kind of power imbalance sort of create barriers toward meaningful participation in terms of reforming legislation or programs in compliance with the CRPD. And I think my last point is clearly we understand what the law talks about, ending coercion, the issue of free and informed consent. It's very clear in the letter of the law, but also we need to start thinking about pilot programs in terms of how do we translate that into practice. Because I've realized, for example, in Africa, sometimes the issue is not that the government don't want to reform laws and programs. It's just that they do not understand how. So how do we end coercion? How do we encourage, participation in community? What kind of support services do people with psychosocial disability need? So that's very, very important. But I really have to emphasize on the need to strengthen organizations of persons with psychosocial disabilities to be able to contribute to this discourse about compliance with CRPD. Thank you, Claudia.
Thank you, Michael. I think it's a very interesting topic, and I can see here on the chat that there are many questions. As we just have around 6 or 7 minutes to the audience questions, I would like to ask you, panelists, some of the questions, and ask please to answer them very directly in a brief way. So first, I'm seeing here, let me see. There is one question for Benjamin. Benjamin, stigma about, it's a question from Haru Abdallah. Stigma about mental health is a common barrier to realizing the rights of people with mental health illness and psychosocial disabilities all over the world. How you are removing the stigma in Liberia?
All right, I am not let's say talking about separating Liberia from the rest of the world, but I'm saying I cannot speak for Ghana, where I don't live in Ghana, or maybe talk about Kenya, where Maka is. So I speak for Liberia. So what we experience, the stigma we experience in Liberia, that's what I'm talking about. I know that stigma for mental health is all over the place. It's all over the world, it's a global issue. So we have to keep fighting to make sure that we disabuse people's mind about people with mental health conditions. So when I'm talking about public stigma, those are the one common, even including social stigma, those are the one common in Liberia here. So I'm not talking about, I'm not really discriminating or like separating Liberia from the rest of the world. Stigma is experienced all around the world. So we as lived experienced people have to keep fighting to make sure that we disabuse people's mind concerning persons with lived experience or psychosocial mental illness and psychosocial disability. I think I already answered that question in the question box, but I just have to say that. Thank you.
Thank you, Benjamin. There is another question from Juliana from Brazil, and I'd like to ask you to Zeenat and Christian to comment it. She asks, how do you understand the role of university to collaborate effectively to create better communities of practice, aiming human rights and persons with disabilities? And she's asking also if you have good experiences with working with communities to share or to indicate here. So maybe please, Zeenat could start answering, and then Christian.
Actually, I'm addressing the second part first. There's a question that having about the community-related question. And I think that, yes, if we can really able to create this resilience within the community, involve the decisions makers within the community, and that can really help us to address these issues to some extent. Of course, as Benjamin mentioned, that stigma is one of the key issues, and that is actually in every country we have that. But if we can able to portray it in a different way, if we can address the root causes, as I mentioned, that there are some root causes against why people is going for this type of decision. So if we can address those and can involve the community, that will be helpful. And the first part of the question I missed a little. Is it about on the university?
Yes, exactly. She was wondering, what's your opinion on the role of the university to collaborate better, to promote, to increase the community of practice, to aiming, of course, promoting human rights?
Okay, particularly in terms of suicide or mental health, it is a bit difficult to talk about that in Bangladesh context, because as I said, that mental health issue nowadays become getting priority in our country. Previously, it was not coming forward like the way we are discussing, but in general, in Bangladesh, the development of social development, in every social development activity, the university is always supporting and coming forward. So it is the responsibility of our development partners also, is our responsibility also to involve the institutes. But yes, especially in terms of drug use and other things, university are really now playing good role, and they are having counseling centers in the university, student counseling centers. Those things are available, and we can utilize those.
Thank you. Christian, would like to make some comment about it?
Sure, very briefly. I think one role universities could have part on is about this issue regarding to think about, the challenges on MHPSS and migrant and refugee population here in Peru, not only so as a challenge, a burden mostly, but it's about shifting the perspective. It's about thinking on the, seeing the community, the migrant and refugees community as a resource, as part of the, part of the solution of a huge challenge, a national challenge regarding mental health and psychological support. So that could be, for starting, a good point. Practically speaking, here in Peru, we have two universities engaged in the discussion. One is the Pontificia Universidad Católica de Peru. They have a master's degree on Psicología Social y Comunitaria, social psychology, and also the Universidad Antonio Ruiz de Montoya, which has a very they have a very interesting institute on psychological counseling. So they both are engaged within the humanitarian network here in Peru. So they have been taking a very active part on this discussion.
Okay, thank you so much, Christian. We have another questions here in the chat, but due to the lack of time, I'm afraid that we can't answer them right now. What I'd like to suggest is to keep going with this conversation on the circle and on the social networks, just to make sure that everyone read it. There is one specifically for you, Christian, that was about the organization CARE, and I would like you, maybe later you could just write, on the circle, as indicated here, the answer for it. And also there was another question from Valentina. It's a very interesting one. And she asks, what is the one key challenge and one key opportunity to strengthen the impact of CRPD at national level? So again, I'd like to suggest you all to write your answers to all the panelists on the circle, which is where we are going to keep going with this conversation. So just to finish, because we need to finish, unfortunately, I'd like to ask to each panelist to give us a farewell with, let's say, a tweet answer, answering to the following: to uphold the human rights of persons with mental health conditions, we must. So can I start with you, Christian?
Can you repeat the question, please?
Of course, it's just finishing the following. To uphold the human rights of persons with mental health conditions, we must, what we must do?
Listen to the people. we need to open the conversation. Stop talking between experts. We need to talk more with experts by experience, I think.
That's great, thank you. What about you, Benjamin? What would be your tweet answer to it?
Yes, we need to respect the laws that we made. That means policy documents that are crafted should be followed. We need to really implement them, because we as human beings, sometimes we are good at, let's say, crafting those policies and those strategic plans, and then implementing them, like the main problem for us. So we need to uphold the CRPD in all aspects. Thank you.
Sorry, Dr. Sultana, what would be your tweet?
Okay, I'm really considering the involvement of the multi-sectoral partners. That is the one thing, and also to implementation of the strategy that now we have.
Thank you. And finally, Michael, to uphold the human rights of persons with mental health conditions, we must?
I think for me, we must respect inherent dignity and personal autonomy. I mean, if we uphold those two principles, then would, sort of promote and advance the rights of people with psychosocial disabilities.
Thank you so much. Thank you, everyone, for being with us today. Unfortunately, we have to finish this session. Thank you, Michael, Benjamin, Dr. Sultana, and Christian for sharing with us such valuable knowledge and practices. And let me remember everyone once more that the WHO Quality Rights e-training is available for everyone. So sign up to it, spread it widely throughout your professional and your personal networks. And let's advance together on promoting human rights in mental health services, starting from combating stigma, which we have talked a lot about this today. To conclude this webinar, I'd like to share with you all that next month's webinar will be focusing on the mental health community's priorities for 2023, and it will take place on 31 January 2023. And I think this is a great way to start the year with this discussion. And this discussion on mental health and human rights doesn't end here. As I mentioned before, this is just the start. So please, panelists, participants, audience, everyone, let's continue the discussion on social media, on the circle, and on all levels of mental health systems. Well, that's all. Thank you again, everyone. If any of you would like to give us a farewell, we still have 2 minutes for it, and that's it. Okay, so thank you, everyone. Bye-bye.
Bye.
Obrigado, Claudia. Parabéns.
Thank you.
Thank you. Bye-bye, everyone.